Welcome everyone to Kavir TV and radio, as well as freeeducation.us. I'd like to thank the organizers for putting this program together. I was asked to speak a little bit about ventilators, specifically in this time of pandemic. We know that the virus is generally a respiratory virus, even though now we have knowledge that it can affect most every body system. However, the patients that become the most critically sick tend to be respiratory patients, and there has been a lot of information and some misinformation about ventilators, what they are and how they're used in management of patients who are suffering from COVID-19, which is the disease caused by the novel coronavirus that has caused the pandemic. What I would like to mention is that I am a board-certified anesthesiologist. My name is Nizam Missaghi. I work in Phoenix, Arizona. I deal with patients who are critically ill or patients who are receiving care in the operating rooms. I chronically manage patients with the need for airway management, as well as getting on the ventilator, which is a tool at the hands of physicians that helps with the oxygenation and ventilation of the patients. So let's first get to a couple of basics. Our lungs essentially have two main functions. The main function is gas exchange, and this gas exchange occurs when the body takes in oxygen at the level of the alveoli. Those are these very tiny little air-filled sacs that we have millions of them at the bottom of our lungs, or within at the distal ends of the pulmonary branch, if you will, where we take in oxygen. That process is called oxygenation, and where we eliminate CO2 or carbon dioxide, and that process is called ventilation. Normally, we breathe spontaneously. Spontaneous breathing is such that through the muscles of respiration, mainly the diaphragms at the bottom of our cavity, as well as the muscles that connect our ribs, the intercostal muscles, we expand our chest, thereby creating a negative pressure inside our chest. The air will rush in, and the part of the air that makes it all the way to the alveoli is where the gas exchange occurs, where the body drops its CO2 and takes the oxygen, and through passive recoil of the lungs, we exhale, and the next breath will ensue shortly after. When patients are suffering from problems of the lung, in particular, if the virus has affected the body in a way that the patient has a viral pneumonia, there is a fair bit of inflammation within the lungs. And what happens is that at the level of the alveoli, where we have these small capillaries that come to the surface and ready for gas exchange, can become inflamed. The lung tissue itself, because it has the ACE2 receptor where the virus tends to attach, can also become very inflamed, and a result of inflammation can be a lot of fluid that's the resultant of our immune system fighting with the virus, collecting within these alveoli, these small air-filled sacs that are supposed to be filled with air, start filling with fluid and inflammation and infection. And that's why if you were to take a chest radiograph or a chest x-ray of these patients, instead of seeing the kind of the black, open, clean, clear areas within the lungs, you will see these fluffy, whited out areas of the lung. Some people are luckier and this process may look more patchy. In some people, the process may look very diffuse, and throughout their lungs, there's hardly any of those kind of black, clear, open fields on the chest x-ray. The better way of looking at it, and there's a particular pattern as to how COVID-19 affects the lung in the case of a viral pneumonia, is a CT scan of the chest, where the radiologist, even without having any laboratory evidence of COVID, say, yes, this looks like the pattern that we've seen with COVID. And unfortunately, it looks very ominous, and the patients tend to have their lungs very significantly affected. So when we talk about ventilators, I think that the public had this idea that ventilators are some sort of a panacea. If you have breathing problems, you get a ventilator and you will be fixed up and you'll go back home. I wanted to first debunk this myth. Ventilators are really a tool to help buy time, to help with the process of oxygenation and ventilation at the level of the lung, however diseased it may be, while the patient's body and immune system figures out a way to turn the corner, if it does or not. If you look at the New York data, um, the numbers of, depending on the hospital, the numbers of patients that ended up receiving a breathing tube, we call it an endotracheal tube that goes from the mouth into the trachea and got connected to the ventilator, the number of those patients who did not make it is as high as 80% in some hospitals. And so the idea that if you have access to a ventilator, you will have access to a cure, it's way overblown. The ventilator is not a machine that without lungs can help you breathe. The machine still depends on utilizing whatever part of your lungs are functioning and trying to optimize that. But the machine itself will not breathe for you while your lungs are very much diseased. There is yet another technology that can help oxygenate the blood outside of the body and return it to the body, but that has its own complications. It's not available at most hospitals except at larger hospitals and academic hospitals. But what we're talking about when we talk about ventilators are devices that you connect the patients to help the breathing process while the patient is essentially sedated or anesthetized and or paralyzed. And so you can imagine these are patients in the ICU. These are not patients who are on the regular ward at the hospital. And certainly these are not patients who are at home on the ventilator. So let's talk a little bit about ventilators. Ventilators are more complex than just a device that delivers a puff of air every few seconds to the patient's lungs. Sure, that's what the ventilators do, but there are many bells and whistles and dials on the ventilators that at the hands of the physicians and the respiratory therapists, they can manipulate those to maximize the patient's oxygenation and ventilation. And we follow these patients through what we call arterial blood gases to see how well we are doing as far as the amount of CO2 that's in their blood, the amount of partial pressure of oxygen that's in their blood, and the amount of acidosis, which is the overall acid-base balance of the body. And based on that, we can adjust our ventilator setting. For one, many people who are having problems with oxygenation, and the reason we know they're having problems with oxygenation is when they arrive to a healthcare facility with a florid pulmonary or lung problem or pulmonary viral pneumonia, they tend to have shortness of breath. You look at them clinically, their work of breathing is increased. They are working more frequently. Their color is not quite normal. And if you were to put the finger pulse oximeter on them, you will see that their oxygen levels that in a normal, spontaneously breathing person, you would expect 95 to 100% is starting to drift into the 80s and sometimes 70s. It's not uncommon for a lot of ER doctors to report that they have a COVID-19 patient who is still talking to them, appears a little bit confused, skin color appears a little bit dusky. They put them on the monitor and the saturation is in the 60s and 70s as far as percentage. That's the oxygen saturation that's very low. You have to find a way to try to better oxygenate these patients. The reason being that if the patient ends up with several hours of low oxygenation, the vital organs such as the brain and the kidneys and the liver can start to suffer, and the patient may end up having some more chronic issues later. So these patients end up needing some method of assistance. A lot of places try to do what we call non-invasive ventilation, which is through things like CPAP machines and BiPAP machines, where these masks are fitted and they try to present some pressure, some back pressure to the lungs. So at the end of your expiration, you still have a little pressure that allows pushing that fluid away from the alveoli and rendering them more functional. And if those kinds of things, or supplemental oxygen through a nasal cannula or a regular face mask or a non-rebreather mask don't work, is the time when you commit the patient to a ventilator. This is a very difficult decision emotionally also, both for the patients and for the providers and for their families. The reason being that knowing that as much as 80% of these patients may potentially not ever get off the ventilator and may never be able to lose that breathing tube. This may be the last time their family gets to actually speak with them. This may be the last time that they get to have any sense of the world around them, because once they get these medications to sedate them and to even paralyze them, they are no longer really there as far as their mind. And so also, if they have a COVID patient, because of isolation precautions, these patients are going to be very isolated and very lonely, quite frankly. They don't have the ability to interact with people, even through perhaps FaceTime or any social media. And so it's a very big decision to make, to put patients, commit the patients to such a thing. Sometimes it's absolutely necessary to buy them more time in hopes that the patient's body will turn around with the help of some other antivirals and modalities that are available to physicians currently. But ventilators, by and large, are a supportive tool at the hands of the physicians and respiratory therapists, and not a panacea that are supposed to help patients completely recover. When we're talking about a patient that goes in the ICU, we should also understand that there is an acute reason why the patient is in the ICU. But going to the ICU and getting committed to all these invasive treatments, such as ventilation, also come with other costs. That if the patients were to survive and turn around and get off the ventilator and start breathing spontaneously on your own, it's not that they just pick up and put their hands in the pocket and walk out of the hospital. A lot of these patients, by virtue of having been on the ventilator for over a week, sometimes 10 days, and not been mobile, because once you're on the ventilator, you cannot go for a walk and your muscles may atrophy. You can have a host of problems that may require sometimes months of rehabilitation. A lot of these patients end up having other issues as well. For example, there's a phenomenon in the intensive care literature called the post-ICU syndrome. These are patients who've had an extended period of time in the ICU. They could have some muscle mass loss and atrophy, so they have to relearn how to walk properly and how to feel strong again, or how to write, or how to hold a cup. They may end up having had some low chronic oxygen that was reaching their brain, and they may have some chronic brain damage, some anoxia or low oxygen issues that could lead to some psychiatric issues as well. It could manifest itself as PTSD, known as post-traumatic stress disorder. These patients may actually feel panicky, if you will. Some of them may have paranoias. Some of them will have memory problems, where memory will not feel so sharp anymore. Some of them will have, while they're in the ICU, because of not moving as much, may end up with bed sores that may become chronic problems for them. Some of them may end up with chronic lung disease, because some of the lung tissue gets scarred and will never function normally, so they may not have quite the same pulmonary reserve and be able to enjoy the same level of activity they were able to do. As well as there can be a process called VAP, which is ventilator-associated pneumonia. A spontaneously ventilating patient, as normal people, you and I having conversations, we have a lot of filtering systems. When the air goes through our nose and our nasal turbinates and the back of the sinuses and the pharynx, before it gets to the larynx, there's a lot of filtering process goes on. There's also on our mucosal surfaces an IgA, which is a form of antibody that helps with keeping the bacteria out. Whereas if you have a breathing tube that connects your lungs directly to the outside world, and that sits there, that breathing tube can get colonized with some bacteria. And not only does the patient now have a viral pneumonia with COVID-19, but they could have a super infection with a bacterial pneumonia. So that would be ventilator associated pneumonia that could potentially worsen the patient's situation. The other thing that's noteworthy about ventilators that should be mentioned is that ventilators themselves can complicate the patient's condition because very high oxygen levels, if they're needed to maintain a reasonable oxygen saturation for the patient, can be toxic to the lungs themselves. So there can actually be oxygen toxicity, which could worsen the inflammation within the lungs. Additionally, there is a pressure toxicity, what we call barotrauma, that could happen that if the lung tissues have lost so much of their compliance, meaning that not like a balloon, they can't quite expand and contract easily and they've become so stiff, you may need very high pressures to generate by the ventilator to deliver breaths. And so what may happen with these patients is that as they receive these breaths, even if their numbers start looking a little bit better, the pro-inflammatory effect of this barotrauma or excessive pressure within the lungs can have a toll. Additionally, a pair of lungs that are so non-compliant and so filled with fluid will become a kind of an extra resistor, so that when the right side of the heart wants to squeeze the deoxygenated blood into the lungs for oxygenation, the right side of the heart may have to work extra hard to try to push this blood through the pulmonary arteries into the lungs. And so what problem there, what we see there is that unfortunately, if the heart has to work very hard, some people get right-sided heart failure, and that could create congestion that backs up in the system and can cause liver congestion, and the liver enzymes can go up. And after that, of course, blood pressures are dropping. And once the blood pressure drops, then even if you're oxygenating the lung very well, if not enough blood is making it to the lung to be oxygenated, you still will have a patient that's spiraling and is in a very difficult situation. So I think the take-home message of this bit on the ventilator is that the ventilator, its availability or lack of availability, will change the overall mortality of this disease, but not by very much. It will not move the needle that much. Still, the most effective way of dealing with this virus is avoiding it, the hand washing and distancing, and ensuring that we have proper mask coverage, especially when we're in enclosed spaces. And because once we are sick, if we happen to be part of that 15% or so of patients that end up in the hospital, and a portion of them that end up in the ICUs, a ventilator is not necessarily a life-saving measure, but just an additional tool at the hands of the doctors. Let me mention a couple of other things that are related to this. I spoke about masks, and when a lot of masks weren't available, people were going to Home Depot and Lowe's and finding masks that are meant for industrial use, and they're very good as far as keeping the particles out. But the masks that have the embedded filter, that plastic embedded filter in the center of them, they help you when you are breathing in to try to keep viral particles or any chemical particles out. But when you exhale, there's not a whole lot of resistance and you are breathing out. So while the patient who's wearing the mask may be protected from surrounding infectious disease agents, they are not protecting people around you from their own exhalation. So if they happen to have the virus, this virus, as they exhale, would go right out of that filter, which is in the center. It actually looks like a filter, but it's actually a valve and not a filter. And they can expose the room around them. The other thing that we know now about this virus is that the enclosed space is a big problem. Outdoors, the ventilation is infinite, so it's far less of a concern as long as distancing is occurring. Whereas indoors, now that we have examples of seminars that have been held in an office space or a singing choir at a church space, even though nobody shook hands and nobody came in contact, just because there was an asymptomatic or a pre-symptomatic person sitting there, a bunch of other people, tables and tables or cubicles and cubicles away from them, still ended up getting the disease. And so the way I want all of us to think about how we get this disease is a function of how many viral particles end up in our body. The current working number is around 1,000. You need about 1,000 viral particles to enter your body for the disease to take hold. And so if that were the case, and somebody who's around you who's not symptomatic, just through their breath, their regular breathing, they could be sending out 20 to 200 viruses at a time. Now, in order for you to get to 1,000, because your mouth is not right next to their mouth and there's dilution in the air, it's only a function of time. If they are just breathing near you and some of these viruses are floating in the air, the longer you're in the same room with them, the more likely you are to start reaching that critical viral particle number for you to get sick. So if you happen to be in a grocery store and somebody just walked past you briefly, even if that person was COVID positive, as long as you were both wearing a mask, I don't think that's a big concern, because even though you were within less than 6 feet, because it was for a brief period of time, through their breathing and whatnot, the overall viral particles released in the air are not that significant. Now, the numbers end up being very different if you happen to be around somebody who's COVID positive who sneezes. A sneeze is very interesting. The particles that come out can move as fast as 200 miles per hour. This is a very significant and fast thing. So it could laterally move within the room far faster than you think. The second thing is as much as 200 million viral particles with one sneeze can enter the air. So you can imagine that if a COVID positive person who's not masked with an N95 mask in an enclosed space ends up doing this sneezing, a lot of people in that space who are far beyond the 6 foot distance could be exposed and could actually end up getting sick. And so this becomes very important. The other thing that we know is that one of the determinants of whether the patients get so sick to end up in the ICU and require ventilation is that initial amount of viral particles. Around 1,000, let's say, is the number that you need to get sick. But what if the first inhalation that you took into your lungs had 100,000 viral particles at once? If that were the case, you may become one of the patients who becomes the sickest of the sick, because all of these viruses set up shop much faster in your system and end up making you much sicker. And so at the end of the day, distancing is important, especially in enclosed places, and keeping ventilation within enclosed spaces is very important, especially in Arizona, when the weather gets so hot and all windows are closed and the air ends up recirculating significantly. I think that we need to be super careful about sharing our room with somebody whose contact traces we are not aware of and whose COVID status we are not sure of. I hope that this has been useful as a introductory talk to ventilators. The one quick thing that I also wanted to say is that I know that there had been a lot of efforts coming up with open source technologies to try to create more and more ventilators that can be provided cheaply and in bulk to cities and places that are less fortunate and underserved. The big issue is this: the modern ventilator is very complex. It's not just something that gives a puff of air 12 times a minute to a patient. It's something where you can use a dial to adjust exactly how much pressure you want to give to the patient with every breath, how much volume you want to give the patient with every breath. They happen to have touch screen screens where you can look at it and a flow volume curve will be available, a pressure volume curve will be available to you, where you can assess the lung compliance. It can allow you to add what we call positive end expiratory pressure, or extra back pressure against the lungs at the end of exhalation, to try to keep your alveoli open, and you can dial that up and down as well. It can also determine what percentage of the overall breath you spend in inspiration versus how much you spend in expiration. And so sometimes, if we want to minimize the overall pressure damage to the tissue of the lung, we tend to reverse that ratio and allow the patients to have far more time in inspiration and take the expiration time shorter to try to maintain better oxygenation for the patient. Lastly, if we were to be very aggressive to try to make the patient's numbers so perfect, get the oxygen levels perfect, get the CO2 levels perfect, even though in a very short run of 1 or 2 days, the numbers may look better, in the long run, we're causing more inflammation and harm to the patient's lungs. And so the current thinking with a lot of these patients is a little bit of permissive hypercapnia, which is allowing their CO2 levels to be a little bit above levels of normal and allowing a little bit of acidosis that comes with that to the patient. And also a little bit of permissive hypoxia, meaning we will allow the patient's oxygen levels to drift a little bit lower and sit there in hopes of not overly irritating and damaging the lungs just from the ventilator itself. I hope this has been helpful as a presentation on ventilators. We try to do these mini series to just help the audience. We've done a similar presentation in Persian with a respiratory therapist, but for the English-speaking audience, I figured this would be timely so that everybody has an overall understanding of what ventilators are and what ventilators are not. Thank you very much for tuning in to Kavir TV and radio, and to freeeducation.us for sponsoring this brief program.